All right, so now we're going to move on to more cardiovascular diseases, and we're going to talk about atherosclerosis. In an artery, you have a middle space where the blood flows through, and then you also have something called the intima, right? So when we are young, like at the age of 11, we start knowing that we love McDonald's and hamburgers and desserts, and our body is like, I love it too, but I don't know where to put all this fat. What happens then is that you start hiding it right here. The body's like, no one will ever find it here. And it goes unnoticed for some time, but it gets bigger and bigger and bigger, and pretty soon you have what we call a plaque. And the body sees that as inflammation. And so what happens then is you have monocytes and leukocytes and macrophages that are all coming and working on this plaque. The problem here is, just as we discussed with aneurysms, we now have an area of this wall that is super stretched out. So the velocity over that plaque increases. When it increases, this stretched out area can be injured. And what we just talked about with Virchow's triad is that if we have an injured part of a vessel wall, guess what's going to happen? Dun, 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 here comes the platelets to the rescue. The platelets are going to come and stick, and they're like, we are doing our job, we are fixing that area, but now look what happens. So now, instead of having this much space for blood to flow through, we now have an amazing clot because our platelets have tried to cover the damage that happened because of our fatty intima plaque. This is what causes heart attacks. Because now, instead of having a little bit of blood flow through, no blood can flow through. When that happens, then obviously whatever part of the heart that vessel is going to can't be receiving the blood, and therefore no oxygen can go to the cells, and that part of the heart dies. That's what we see in a myocardial infarction. So as we see, childhood arteriosclerosis starts way early, all right? It starts when we're kids. And over time, that plaque increases until we get to the age of 50. I would know that and know all these risk factors I'm going to mention, okay? Risk factors for cardiovascular disease are the fact that age over than 50, family history, hypertension, smoking, hypercholesterolemia, and diabetes. In fact, diabetes is a big one because we already have pressure on our arteries, okay? So I would be aware of all of those. The other thing I want you to know is the lab tests, and I'm going to put them up here on the board too. So look at this visual. So total normal cholesterol should be less than 200. HDL, think of HDL as your happy or high density lipoprotein. You want that high. That should be greater than 40. LDL, think of that as your lousy cholesterol, and that should be less than 100. And your triglycerides should also be less than 150. I would be aware of all of those in case they pop up on an exam. Okay? All right, in terms of disease prevention for this, we need to exercise, follow a low-fat diet, make sure that we if you're diabetic, that we have your glucose under control, as well as smoking cessation is a big one. All right? So what I just talked about in terms of atherosclerotic disease can happen in any vessel, all right? So you'll see there a paragraph about coronary artery disease. That's obviously when you get inflammation and those fatty plaques in the coronary arteries. You also can get it in the carotid artery. And when it happens in the carotid artery, that's when we worry about stroke. We also need to talk about hypertensive heart disease. So hypertension is the #1 primary diagnosis in the United States because it's so prevalent. And the main reason for it is just essential. We just get it as we get older. And part of it is just because we can't dilate and constrict our arteries like we used to. Part of it's because we have calcification in our arteries. But big picture, the older you get, the more likely you are to have it. In fact, when you turn 70, 75% of patients have hypertension. Now, in terms of how we treat hypertension, there's something that came out called the JNC7. And the JNC7 states that there's something called pre-hypertension, all right? Pre-hypertension is 120 to 139 systolically. It suggests that we don't treat that, but we say you need to watch your salt, you need to exercise, lifestyle modification. When that blood pressure hits 140/90, then we bring on medical treatment. Okay, I would be aware of that and know what the number is for true hypertension. So I would also make sure that you know the risk factors of hypertension. I think this has been hit on the boards before, so make sure that you're aware of it. So the big thing, and like we just talked about, is age. The older you get, the higher chance that you're going to have hypertension. Family history is a big one. Race is a big one. African Americans having the highest chance of hypertension and Asians having the lowest. Also, obesity, diabetes, and smoking. Make sure that you're aware of all that. Okay? I did put a box there about how to take a proper blood pressure. I would just read through that just to be aware of what literature says is the appropriate way to take a blood pressure as well. Okay, let's move on. Now let's move on to congestive heart failure. So a couple things here that I would definitely know, because I've seen a couple of these on your exam, is basically what is congestive heart failure and what causes it. So if you look there, congestive heart failure is caused, or we define it by two ways. Look at number one, number two. Number one, the inability for a heart to fill with blood, which we call that diastolic heart failure, or the inability for a heart to pump blood, and we call that systolic heart failure, okay? We also group it into left-sided heart failure and right-sided heart failure, and check out this visual. So here's your heart. When you have a heart that is in failure, it's either going to have left-sided heart failure or right-sided heart failure. So let's look at the left side of the heart. The main reason for the left side of the heart not to pump is because of a heart attack, a myocardial infarction. When that muscle dies, then it can't contract as well. If it can't contract, it can't do its job of pumping blood out of the ventricle to the rest of the body. But that blood has to go somewhere. So what happens then is that blood goes up into the pulmonary vasculature and causes pulmonary edema, resulting in what we call dyspnea on exertion. So shortness of breath with any movement. These patients also have a hard time laying down in your exam room, for example. So if you're examining a patient and you lay them flat and they start having shortness of breath, you need to be aware of their congestive heart failure possibility. So now you have all this fluid in the lungs. Well, that obviously then is going to affect the right side of the heart. When the right side of the heart can't pump blood through the pulmonary vasculature like it should, it gets tired and it starts pumping. But again, it can't pump enough blood into that vasculature because it's already saturated. So then what happens is that fluid goes back into our lower part of our body, causing ascites of the abdomen and lower extremity edema. So patients with right-sided heart failure have a tendency to have big puffy legs and stomachs full of fluid. Again, what kind of edema is this? Yes, transient fluid or non-inflammatory edema. All right. The most common cause then of right-sided heart failure is left-sided heart failure. And if they're going to ask a question about this, it's probably what causes left-sided heart failure? Right, a myocardial infarction. Okay, so other things that you would need to know about congestive heart failure is the risk factors. So risk factors include coronary artery disease, which makes sense, cigarette smoking, high blood pressure, diabetes, and also valvular heart disease. I'd be aware of those things too. All right, so we're moving on to rheumatic fever. So rheumatic fever is a disease between like the ages of 5 and 15 where kiddos get strep throats. And if strep is left untreated, then that can go and land on the heart valves and cause rheumatic fever. And I want you to be thinking of strep when you think of endocarditis, in case that's on your exam, all right? Common signs of patients who have rheumatic fever, they're gonna have rheumatic fever, obviously they're going to have a fever. I would check an ESR. They also can get red hot joints as well as endocarditis. Okay? All right, bacterial endocarditis. Again, we've talked about this a lot, so let's move on from there to heart palpitations. The only thing I think you need to know about heart palpitations is PVCs. That's the most common type of heart palpitation, and y'all have gotten it. It's because of too much caffeine, not enough sleep, stress, pregnancy. Everyone has had at least one of those. So I would know that, and then let's move on. All right, we're done with cardiology, and now we're going to move on to the nervous system and neuromuscular diseases. You guys are doing great. Hang in there with me. Remember, this is one of the big 5, so there's a lot of information here to cover. So the first thing we're going to talk about is cerebrovascular diseases, the big one being stroke and TIAs, all right? So TIA stands for transient ischemic attacks. Now, transient, temporary. So by definition, these have to be less than 24 hours, but usually patients will put a really small time frame on it. Like, I felt like I just couldn't move my arm for a couple minutes, or I felt like I couldn't see for a couple seconds. So not very long. So by the time they actually come to a provider, their symptom is usually resolved. But patients who have had a TIA, obviously we need to be worried about them for possibility of stroke, correct? So 2 types of TIAs. You have 2 big arteries that I want you to be aware of. The first is the carotid artery. When a patient has a stroke in the carotid artery, they're going to have ipsilateral vision symptoms. So if they say, I feel like I just couldn't see out of my right eye, we need to be worried about their right coronary. Or if they say, like, I feel like I just couldn't use my left hand, these patients with the carotid artery will have contralateral issues. So left hand still means right carotid artery, all right? The next one is vertebrobasilar, and that again runs up the back. These patients can have a whole host of issues. I wouldn't be too concerned about that, all right? But patients with TIAs, we need to be worried about them having then a stroke. And stroke is one of those things that we just cannot predict necessarily who will or will not have one. But in terms of main risk factor, I want you to highlight hypertension. That's the big one, okay? Uncontrolled hypertension, huge problem with stroke patients. Also, again, diabetic patients, hypertensive patients, tobacco abuse, age somewhat. Obviously, the older you are, the more other comorbid diseases you have, but I have seen younger patients with it as well, all right? In terms of different tests that you can do, if you want to think about auscultating the carotid artery, sometimes you can hear a bruit, which is a sound over an area of inflammation. Sometimes you can hear that, sometimes not. Otherwise, we use a CT scan to determine, after a patient has a stroke, the location and the severity of what area of the brain was damaged, okay? There are 2 types of stroke that I want you to be aware of. The first one is ischemic, and that is the majority of strokes. That is 80% of strokes, and that is when a patient has what we talked about, like a clot, okay, that breaks off from the carotid artery and starts moving up in the vasculature, okay? So it moves up, it gets stuck. When that happens, then obviously no blood can go further past that, so that area of the brain can't receive oxygen and those cells die. Makes sense. The other type is hemorrhagic, with subarachnoid hemorrhage being the main one. And here what happens, same thing, but there's no clot. Instead, there might be an aneurysm. When that aneurysm breaks, then you have blood flowing out. If blood is flowing out of the area, it still can't get to the brain, again, causing death to that tissue. All right? When we think about a patient with a subarachnoid hemorrhage, if you look at those 3 bullet points there, a lot of those patients have changes in consciousness, but they don't have to. Look at the 3rd bullet point. The biggest reason for this, and it's in bold letters there, is a rupture of an intracranial aneurysm. I would know that the main place for that to happen is the circle of Willis. And that's because the circle of Willis, as you guys will read in like neuroanatomy, has a ton of bifurcations. And when a vessel has all those bifurcations, it can become weaker, hence exposing an area where an aneurysm can more readily happen. All right? Okay, I did put information there about the circle of Willis as well as the different arteries and where they're located. I would just read through that, but don't spend too much time on that. All right, let's move on to headaches. Headaches are more low yield. You can read through the different types: cluster, tension, migraine, temporal arteritis, we've already talked about. And the last one is brain tumors. I guess the biggest thing that I would point out from this section on brain tumors is that 2nd bullet point. Look there how they interrupt sleep. That's important. The other thing I would know is if you look at that last bullet point, it is very rare for somebody just to have a headache and have a brain tumor with no other symptoms. Usually there's one or more other neurological symptom that goes along with it. So if you have a headache in the middle of the night that wakes you up, not necessarily a brain tumor, people. All right, let's move on. Let's talk about diseases of the central nervous system. The biggest one here is being meningitis. Now, meningitis can be viral or bacterial. The big thing I want you to know is the triad in that 3rd bullet point, all right? Has a classic triad of fever, headache, and neck stiffness. All right, meningitis has kind of made a comeback and we have a vaccination for it now, so I would know that as well. But definitely fever, headache, neck stiffness, meningitis, be aware of that. So let's move on to nervous system neoplasms. So the first thing I want you guys to be aware of is glioblastoma multiforme. And what I want you to know about that 1st bullet point, highlight it, most common primary malignant brain tumor, all right? With that said, check out that box there. The most common type of brain cancer is one from metastasis, or one that we would call secondary, okay? Meaning it's coming from the lung the breast. I would write prostate in there. Be aware of those things, okay? So again, if we see somebody who has a brain tumor, we're like, where did this come from? We wanna make sure there's no other sites that's causing a metastasis brain tumor. Okay, so then let's move on. Meningioma, that's the most common primary benign tumor. It usually happens in middle-aged females. And then look at schwannoma. Schwannoma, tumor of Schwann cells. Look at that second bullet point. If it is located on the acoustic nerve, then we call it an acoustic schwannoma. Just be aware of that definition. And then the last one here is pituitary adenoma. We're going to talk a lot about the pituitary gland and physiology, but if you have a pituitary adenoma, it can be functional or non-functional, meaning it can be secreting pituitary hormones or not. So these patients, if they have a pituitary adenoma, can have problems with all of the pituitary gland hormones, and we'll talk about that more in physiology. All right. A couple other things we need to talk about the nervous system diseases are the first one, multiple sclerosis. This is in our demyelinating diseases, and multiple sclerosis is an autoimmune disease. It affects women more than men, like we know about our autoimmune diseases in general, and these patients have demyelination in the central nervous system. The other interesting thing about multiple sclerosis is that it usually happens in patients in northern latitudes. And so we're thinking that vitamin D, or I should say lack of vitamin D, during when their mom had them in the womb is causing part of the MS disorders that we see, because it's not unlocking genetic coding, which is kind of interesting. But the diagnosis of multiple sclerosis, you have to have 2 separate central nervous system lesions on 2 or more occasions. I'd be aware of that. And the other thing that I would say is that it includes the white matter, so highlight that. A patient who has MS often complains of just being super fatigued. They might say, I just feel like my legs aren't moving right, and they often have ocular components too. So blurry vision, nystagmus, diplopia, things like that, all right? So the next one is Guillain-Barré syndrome. And Guillain-Barré syndrome also is a demyelination disease, but it's in the periphery. So these patients might say they just feel like they couldn't get up and go or use some of their fine motor movements, because it's demyelination in the peripheral nerves, so their fine motor movement is diminished, okay? Next is myasthenia gravis. So myasthenia gravis, again, autoimmune disease. This one is a blockade of neurotransmitter signals with the acetylcholine receptors. So I would highlight acetylcholine receptors right there before the number 59. All right, this is more common among younger women and older men. And one time I was teaching this, and this gentleman goes, oh, like Hugh Hefner. I'm like, Hugh Hefner? And he's like, yeah, you know Hef. I'm like, well, I do, not personally, but I know who he is. He goes, you know, young women, old men. I'm like, oh, okay, that makes sense. I can think of a lot of other diseases to put with Hugh Hefner, but we'll put him with myasthenia gravis right now. So, myasthenia gravis, young men, old women. Also, I want you to highlight thymic tumor, okay? A thymic tumor, the thymus is a gland that disappears the older we get, but it can become cancerous with myasthenia gravis, so I would know that correlation. These patients, when they have myasthenia gravis, it can just affect them ocularly. So they have ptosis and diplopia later in the day because those muscles get tired, again, because of the lack of acetylcholine. Or the other thing that we see a lot is they have respiratory weakness. So systemic medicine, you get respiratory weakness. You can also get weakness of the jaw muscles. So I would be aware of that. All right, let's move on. Still sticking with neuro, we are going to start talking about the neurodegenerative diseases. And the first one's Alzheimer's. So Alzheimer's is a disease that we still don't know what exactly the cause of it is or how to treat it. But we do know that these patients get these plaques in their brain made out of beta amyloid. We also know that these patients then can get these neurofibromatosis tangles that we also can see on autopsy. The most common form of dementia is Alzheimer's. I would know that, and I would just make sure that you highlight that in the second bullet point. Vascular dementia is also very common. Again, when we talk about vascular system, our brain is fed by so many vessels. And again, these can get little plaques in them, and they can get atherosclerotic. And so when that happens, again, different areas of the brain do not get enough oxygen and therefore can die. These are smaller. Still, it's a very common form of dementia in the elderly. Be aware of it. And the last one is Parkinson's. Parkinson's, I would definitely know. I would know the neurotransmitter and where it is affected in the brain. So with Parkinson's, I would know that it is a deficiency of dopamine. Does anybody know what an excess of dopamine gives you? Schizophrenia. But a deficiency of dopamine causes Parkinson's disease. I would also highlight there, right first bullet point, last two words in the substantia nigra. That would be important as well. So decreased dopamine, substantia nigra, and I would also know the classic symptoms, and they're there. And we say it in TRAP, okay? Parkinson's is a TRAP. T standing for tremor. And what that tremor is, it's this fine pill rolling tremor. And Michael J. Fox has kind of put just a person behind Parkinson's for us. And if you notice in his latest works, he always has his hands in his pockets or he's doing something. Because if I would go reach for a cup of coffee, then my fine rolling tremor stops, all right? So tremor. The next one is R, rigidity. So if I would take a patient who has Parkinson's and move their wrists like this, instead of being nice and fluid at their elbow joint, it would more look like this, okay? Very rigid patient. The next is akinesia, which basically is the inability to start a movement. So they have a hard time getting going. And Michael J. Fox, you can kind of see him doing that. Some of that's medications. Some of it is just your body is a little delayed in where you need it to go. And then the last one is postural instability. So these patients, when they walk, they try to hold themselves upright and they kind of stumble forward because they have a hard time keeping upright. The other thing that you see with these patients is flat affect. These patients also start losing some of their emotional facial cues, which you can see in also people like Muhammad Ali and different patients like that. All right? So let's talk about trauma and get this wrapped up. So trauma, the only thing I want to say about trauma, epidural hematoma, I would highlight middle meningeal artery. So if somebody gets hit in the head, that middle meningeal artery is the one that's most likely to be damaged. So I would highlight that. Subdural hematoma, I would just highlight that first line. I would know that it's blood collecting between the dura and the arachnoid space. Highlight that. And then last, just symptoms to watch for, changes in pupillary size. And people are like, well, why? Well, if you ever see ER or any one of those movies, they bring in this patient and they're whipping out their pen lights and looking in their eyes. And they're like, yep, that looks pretty cool. What are you looking for? But anytime you have blood in the brain wants to sneak out. It needs space. It doesn't like being pressurized. So it'll start herniating into the foramen magnum, and that is where your pupillary reflex is. So that's what they're looking for when they're looking with their pen lights at the pupillary size. Also, vomiting, nauseousness, and then loss of consciousness too. So that wraps up our neuro.